We're very thrilled to have two distinguished NIH officials come and talk to us. So what we're going to do is they each have a couple slides to present, and then we're going to open it up for questions. And this is where we really want to make sure we're interactive. They're here to provide insights, guidance, interpretations, whatever, but please think of your questions now, because we want a lot of questions.
And make it provocative.
And remember, we are live streaming, so.
And Chris says that because the probability that we're going to know what the answer is very small. Make them as provocative as you want, and, because federal employment is very secure these days.
Just no racism.
So first off, we're going to have Dr. Paul Gaist from the Office of AIDS Research at NIH, and he can tell you all about the rest of, the fancy stuff he does.
Thank you very much. Okay, I actually have something else to say about the fancy stuff. First of all, I want to thank the symposium organizers for having Chris and I here today. I'd also like to acknowledge Ms. Amber Wilson, who's right here in the front. She is on staff at the Office of AIDS Research and works along with me and is really an indispensable part of the OAR team. And before I start, there's one more thing I'd like to point out. I'd like to add a historical notation about our session moderator, Dr. Melissa Davy Rothwell. I just want to point out that she taught with me in one of my courses here at the school back when she was a PhD student and went by the name of Melissa Ann Davy. And now we blink and look at this.
And I'm still talking to you.
After that horrible experience, right. So, I assume, there we go. So, and again, I actually think it's a nice order to have JD Justin give his talk, and then we're going to talk about the sort of what we try to do at the NIH in relation to implementation science and HIV. I'm going to start out sort of in the global, the broader, the more the 50,000 foot view, and talk about, there's different, you probably have heard or seen different mission statements for the NIH. The one I think that is official and it was updated a little while ago, and it's the one that I like actually, is that NIH's mission is to seek fundamental knowledge about the nature and behavior of living systems and the application of that knowledge to enhance health, lengthen life, and reduce illness and disability. And it's that and the application of that knowledge that I think really comes to the heart of this meeting and the work that we are doing and all of you are doing. I'm also going to start with what I think we can agree are accomplishments in HIV/AIDS as we stand here today. That in the last 30 years, we're here today, a fatal disease. It's become a chronic condition. People with HIV are having near normal life expectancy. Over half of the world's HIV positive individuals receive ART. We have biomedical prevention interventions such as PrEP, treatment as prevention, condoms, male circumcision that are deemed effective. Behavioral social science-based interventions are reducing HIV incidence and improving lives. And I have here as an accomplishment implementation science being critical in furthering these accomplishments listed and future accomplishments. And I have it listed as an accomplishment, even though I agree with Justin's statement that, or actually it might have been Dr. Chasen's statement, that we are really developing, we're emerging in implementation science in relation to NIH as well as HIV. And I've listed this here because many of you here, those of you who are streaming from Northwestern, and others at research, academic, and community settings have been pushing this to the forefront, have been helping others see. And I think Justin's presentation underscored that there are researchers who are doing and not seeing. There's researchers who are stuck in thinking implementation is something that is done later or by others. And the experts here, the experts at Northwestern and at many other settings are changing that dialogue, producing the research, and are pushing this forward. We also, as we all know, have a lot of challenges, still many, such as, and this comes home to all of us, both at the NIH and outside, that we are in a flat funding situation for research, for AIDS research, I should say. And Justin, in one of his slides, showed sort of the percentages for implementation science. And I saw the last 2 years is something like 22%, and then the next one was pretty much close to that. And if you're holding your own these days, that's not a bad thing in a flat funding. It doesn't mean we don't need more of that research, but there are other areas that are actually losing and sliding. We don't have answers to that, but Chris, I, and others at NIH are in there fighting every day to protect the research portfolio. We know that the epidemic spans across lifespan, and we're seeing rising rates among specific populations. We're seeing an older population and a younger population that needs our attention. We increasingly have comorbidities, co-infections, and complications, and the issues we've been talking about it for an awful long time, stigma, scale-up, adherence, and lack of fully integrated approaches remain a challenge. And if you look at that, it really, implementation science has a role in helping move these challenges to solutions. Now, the NIH AIDS Research Program is multidisciplinary in its approach and reaches across the lifespan. And you'll see major areas listed here, including implementation science, and I'll talk a bit more about that in just a moment. But to give you some, I'm a bureaucrat, I've got to give you at least one of these slides, right? So I just wanted to position the Office of AIDS Research that Amber and I are in, and these are our institutes and centers at the NIH, 27 institutes and centers. Not all of them are conducting HIV AIDS research, but the majority of them are. And the director of our office, Office of AIDS Research, is now approaching the 2-year mark. I think she's reached the 2-year mark, and that's Dr. Maureen Goodenow. And our office has the responsibility of coordinating the AIDS research program across the 27 institutes, as well as being the NIH voice outside of our agency and to other agencies and other entities that are working in the HIV AIDS field. We try to capture our role with catalyze, coordinate, and convene. These are the institute centers and offices that are invested in HIV AIDS research. You can see it's quite a lot, and this is all an acronym thing here, but I think most people here and streaming know what these are. And I'll go on to that. The Office of AIDS Research vision is pretty straightforward: end the HIV pandemic and improve the health of people with HIV. And how does that get operationalized? It's getting operationalized through 5 overarching high priority research areas. We've been in cooperation with the institutes working on this to make this as meaningful as possible. I'm just going to say in the shorthand, even though it says reduce the incidence, we have prevention, next generation therapies, treatment, we have comorbidities, co-infections, complications, and cure research. And the 5th, cross-cutting areas, those are the areas that apply not only in and of themselves, but across all 5. It relate to the other 4 overarching priorities. And while the other columns are examples, The cross-cutting are the research areas and areas of investment, and implementation science is called out as one of those high priority cross-cutting areas, along with basic science research and behavioral social sciences, etc. I just plucked out a few examples of FOAs current FOAs that are HIV-related implementation science. Just a few. We all should know grants.nih.gov funding to go and find out what the active and current FOAs are. I think they tell you that the first day of graduate school, at least Hopkins. And what I want to point out, I'm not going to go into each of these. I want to point out the diversity of the institutes. So you have mental health and nursing, alcohol, drug abuse, minority health, and here also, as Justin pointed out, on this one, I'll just focus on that we have also the various mechanisms under these funding announcements. An uncurated look online at the NIH Grants Guide, using and focusing on HIV implementation science, came up uncurated with 958 FOAs. I'm looking at Amber because she gave me that number. So again, one of the things in terms of what JD talked about, some of the issues, and I think Dr. Chasen also said this, has to do with one of the countermeasures or one of the pathways to improvement are getting funding opportunities written well. And so one of the things that may be important to look at is how are these FOAs being written, and feedback on that actually could be a project, could be something that would be helpful to the NIH. In addition to the funding announcements, NIH has a lot of implementation collaborations. Now, not all of these are HIV focused, but again, that gets to the issue that we don't necessarily want to silo HIV-related implementation science from all of implementation science, and that there's cross-pollination and a lot to learn from each other. I'm not going to go again through a lot of these in depth on these, but the Adolescent HIV Prevention Treatment Implementation Science Alliance, that's a collaborative effort between our Center for Global Health Studies at the Fogarty International Center and the U.S. Office of the Global AIDS Coordinator. It aims to enhance the effective use of evidence and help overcome implementation challenges related to prevention, screening, and treatment of HIV among adolescents ages 15 to 24 in sub-Saharan Africa by catalyzing collaboration and communication among implementation scientists, program implementers, and policymakers. The Human Genome Research Institute has Implementing Genomics in Practice. NIMH has its research partnerships for scaling up mental health interventions in low and middle income countries. And the PEPFAR NIH Prevention of Mother-to-Child Transmission Implementation Science Alliance aims to support effective implementation and evidence-based interventions to prevent PMTCT. And NCI, I want to bring your attention, there's not only, and it says NCI, but it's a Trans NIH Dissemination and Implementation Working Group. And that's an internal NIH working group. And Chris tends, for some reason, for me, doesn't like me to say this, but I see him as the co-chair of that working group. I think that's fair. But if not the co-chair, he's certainly one of the drivers and one of the leaders of that. I want to also bring your attention under this is that the NIH has an annual dissemination and implementation science conference at the NIH, and it would be reasonable and worthwhile to take a look at that online to see if you're in the neighborhood, come on over. And it's open to everybody. And there's also dissemination and implementation training programs. And you can find out this and more information about this at nih.gov. Dr. Goodenow, the director of the Office of AIDS Research, recently gave a talk and had a call to action slide. And none of these are surprises. And you see at the bottom, conduct implementation science that shapes national policies and prevention care guidelines. But if you look at the other call to action, implementation science is needed for most, if not all, of these challenges. And to sum up where the NIH is, besides saying that NIH holds HIV-related implementation science and implementation science overall as a high priority, we are, in fact, moving to the position that, as we see it, the implementation science is in tandem with the development of the new interventions. And this is from a paper in 2013 by Dr. Fauci, and we are capitalizing on this as a tool to further this perspective at the NIH. And I think that is where I'm at. Okay, and I think it would probably be best if Chris gives his presentation, and then we'll just do question and answers after that. Okay.
So I'm Chris Gordon. Thanks for the kind words, Paul. I was thinking as this meeting was being convened, I'm an optimist and enthusiastic about this work in this space to begin with, but it was in 2013 that Alvin Gang and colleagues hosted an implementation science symposium at UCSF CAPS, and I was just during the last session looking at my slides, hoping things had changed, because the title was also NIMH Perspectives on Implementation Science and Priorities, and thankfully it has. There's a lot more. There is a lot more implementation science. We are funding more implementation science. As more people get into this space, I do think that it's so terrific that this inter-CFAR working group has happened to help coalesce and help the field define the highest priorities. I'll eventually get to my slides, but I'm going to be very brief about the slides. I just thought this was important to note because we don't want to eat our young. And there's a lot of good stuff happening, and as Dick said, we want to make sure that we balance rigor and relevance, and part of it is coming from theory. Part of it may just be good ideas that we attach a theory to that seems reasonable. I also note that I'm not sure if Elvin just called the implementation research that we should love a giant fish made of garbage.
That's your take home.
So here are the top line. Part of the top line message is that there is one of the things that was great to see was that there in fact has been a trans NIH push. It hasn't just been NIMH or a few institutes. There have been initiatives from NICHD, from NIDA, from NIAAA, and so I'm really here, and Paul is to represent all the institutes, even though everyone couldn't be here. That we really do represent a team approach to this, and we have a trans NIH work group, and you'll see that in the published literature. The challenge really is that it's just with every new tool there's more to do, right? And so I think with a flat budget and with more applications coming in this space, I really think it's going to help. I see the CFARs as sort of nodes to help spread the word about how we can harmonize and advance the field and target the highest priorities. One other thing, by the way, that's changed is that there are now 11 Ks in my portfolio that have an implementation science focus. And that's really remarkable given, 8 to 10 years ago, I might have discouraged someone to get into this space because it was really hard to define and launch a career. And so I forget when your K was funded, Melissa. No, okay, that's right. And I will say one other thing that's changed as I went back through my slides from 2013 is that, and I observe this and also live it, that the partnerships between academic, government, public health, collaborative agencies like CDC and PEPFAR has never been stronger. And I think that there is this shared appreciation of some of the value of this work. There's still negotiation that has to happen about how you balance research and service, but I think we're in a great position. And so I'm trying to exude some optimism about what good can come out of this exercise of trying to help define and prioritize the field. I enhanced this slide to show it is in blue. The blue ones are the ones that have a footprint in HIV implementation science. And for those interested in actually, to my mind, it's been NHLBI who has had the most of those interested in those issues in HIV over the last few years. You know, we tend to have more FOAs, so iterations of our priorities, and we don't have a lot of money to set aside. I mean, NIH has a relatively smaller budget, and so we tend not to have set-asides, but that's certainly something that we could look at if this group comes up with a sort of refined set of priorities that could help guide the field. So as Paul said, we're open to input on shaping RFAs. So I hoped, actually, I also meant to say that I wanted to share something new. It's great that this session is titled Perspectives because I have lots of perspectives, but I also want to be helpful to you. So here's some of the things that have happened over the years. There were only maybe 4 or 5 bullets in 2013 that kind of described all the various activities that have gone on in this space. And I'll just whip through this slide. I'll share the slides so you can keep them, but there really has been a lot of energy in this space that we have helped to coordinate. So yay. One of the things that I could be helpful with, NIMH has concept clearances. All the institutes have concept clearances, and so you should take a look at those. Their advisory council does them, and so it's really a hint of what initiatives are going to be in the next fiscal year, the fiscal year after that. And so some of the things that I'll allude to about, for example, this last bullet, that it is highly likely that we will have an initiative around PrEP implementation science in PEPFAR settings. It is highly likely that we will advance some work on the intersection of mental health screening and treatment in HIV AIDS care settings, but I can't tell you that we are. Other things that have changed since 2013, you know, we live in a rarefied air, I think, at places like the CFARs that are really thinking ahead of the curve, even though the fact is that you know, implementation of Treat All is just starting. So there are opportunities in this area that we have to figure out, again, the highest priorities. I'm going to give a plug for a paper that Alvin wrote with Diane Havler that I thought was really thoughtful, which he alluded to in his talk. And this was around, you know, rapid start. And, you know, how do you do that? And the how you do it, for us, the implementation science, is just as important as does it work in some way? Can it improve outcomes? But how do you change, you know, systems and organizations to absorb or innovate with some of these and sustain them? So there's questions about, the same way that there's questions about retention and care that we need to study better simply because they're challenging to do because you want to look over time. There's questions about sustainability of some of these innovations that I think that there's some room for growth. I just wanted to mention a few areas that we are also interested in supporting with further implementation science. I mean, you might sort of call some of the work in this space differentiated care. It seemed like it used to be called task shifting, but then when you go to the IS conference now, there's so much focus on differentiated care, which is great because I think it's broader. It's not just about individuals sharing tasks, but system change. And as I mentioned, our interactions with Ambassador Birx and PEPFAR have grown stronger over the years, and in some ways these are the critical questions, right? It's the doing the right things in the right places right now in the right way. I think that's some of the challenges about working with any implementing organization, as I learned many times from Nanette Benbow in Chicago over time, is they need answers to these questions yesterday. And waiting for a 5-year study ain't going to work. And so there has to be some balance with an expedited schedule. So these are a few points about adherence and retention, which I think that I have covered. And I did mention that I think we are particularly interested. We have far more work early in the care continuum with implementation science and less so in retention. Wanted to highlight one key example of how we're working closely with CDC, and I would expect more initiatives like this where under the leadership of Mike Sterrett and Susanna Allison and their colleagues at CDC, who, by the way, also helped to be here. I mentioned the NIH, Trans NIH group. We have a trans agency group that's working with this inter-CFAR work group too, and that includes HRSA. We funded supplements to attach implementation science to existing Project Pride demonstration sites, and so those were intended as seeds, but really intended to help build the collaboration, make sure the research didn't get in the way, and have the questions in large part driven by the needs of the implementers. These are a few, I just include these slides that I want to go through quickly so that you'll have them. A few of the types of studies that have been supported by that CDC opportunity with NIH. Is that my last slide? Yes. So just to reiterate, for us, priority areas, and I would say that, one of the challenges that we're having to do that I think this trans-CFAR, inter-CFAR group can help with is trying to figure out, this is from our perspective, from NIMH, but we need to have sort of a fuller perspective from all the different institutes about the areas that we want to support, how we're all going to sort of split up the workload so that other institutes also contribute to this, since it's unlikely that there'll be an increase in support for a particular area. I guess unless, of course, that there's a plethora of grants that fall under the 10th percentile in this space, and then we'll have to fund them. So I'll stop there and leave some time for questions and discussion.
Great, so we have time for some questions. And Anne's in the back if you need a microphone, or up here.
I have a question.
Well, you have a microphone.
Is JD still? Oh, there you are. It was something when you were presenting and you had cost, and it made me think: is cost sort of a parental term in terms of underneath it? Was it cost effectiveness, budget, like essentially Chris had on his slide? Was it just cost, or did it?
So this is part of our sort of over-inclusiveness. If they mentioned cost as an outcome of any sort, it was included. But yes, there were examples of cost-benefit, benefit cost, cost-effectiveness. And I think emerging is the health economics of implementation, which is different, of course, than a typical cost-effectiveness analysis where you need intervention effects. And in implementation, you don't necessarily need an effect size or an actual clinical level effect to determine the implementation cost and potential cost benefit. So it was over-inclusive.
Thank you.
Thanks. What's that? No, I'd love to follow up, Chris, on your the comment you made about PEPFAR and the engagement of the implementation science agenda on the PEPFAR challenges and the big questions there. Because I think one of the things that was very clear this summer in Amsterdam was, we're now at the point where we've seen some of the very big trial results. We are looking forward to PopArt 071. I don't know what the total bill is going to be, but it's over 200 million. And I think it's very clear hearing from the PEPFAR folks that they have much more enthusiasm now for the public health impact assessments as a way of looking at the outcomes that they seek to see, improvements in the care continuum, now in the PrEP continuum as DREAMS rolls out PrEP. And that seems to me a very fertile area of investigation. But I think also, some real challenges there about sort of the quality of those data and the ability to use institutional data sets to answer questions. And this is obviously highly relevant here as well. So it seems to me that there's a real role for NIH-funded research to get into that domain. And just really a question if you think that that is part of what engagement around PrEP is going to look like. I think, for example, some of the work that Elvin and his group did on the mortality and missingness, and who actually is missing, and what does that mean? And are they dead, or have they sought care at another place, or are they defaulted from care? That's critical for this next phase.
Or
Right?
can't they be found in the first place?
Or can they?
Like pop art, just having trouble with some of that.
Yeah. Indeed.
Yes. Well, I just as in preparation for a different presentation, I noted that in the work in my portfolio right now, which is about 70 grants that I'm just responsible for, there were 28 that collaborated direct. Their work was being done at a PEPFAR site. And so I do think that regardless about what leadership thinks about, the trade-offs between, and I think that there's something more positive in the public health assessment approach. My sense is that those on the ground appreciate it, because you get the immediate feedback loop of if you're doing a trial that can improve things on the ground, sure, eventually it might lead to a publication. The short term, it's helping at those sites. Can I just, I forgot to mention one more thing, which was prompted by your question, which is, it's just anecdote, but over the years, I think that some of the most, your work accepted, some of the most innovative implementation science work has been done in low and middle income countries. And when I think of some gaps that we need to fill as an institute, I think of work in rural areas. It was in Patrick's presentation, I think, that just showed the disparity in access to prevention in those areas, and how so much of our work, for better or for worse, is funded in epicenters, and creatively internationally, maybe because they're, some of the differentiated care, tailoring to adolescents and extending service hours and all these things. I mean, we would encourage that kind of focus in the States too. It's happening, but we'd like to see a cascade of that. Yeah, Mike.
While the mic is walking back, I also would like to say it's interesting too, I think, in the dialogue of all of this around implementation science research. Again, I'm referring to JD. He had one of his take-homes about a paradigm shift. NIH for the longest time actually had to get comfortable with translational research, and we're now building beyond that on implementation science. And the dialogue around the terminology, because sometimes if something comes in and it looks like this is operational research or services research, or implementation research, how does that fit together? And it seems like there are opportunities there. So I don't know if you guys have thought about that and taken that on, but okay, mic is in hand.
Yeah, so thank you both. Question about retention and care and where that fits in. I think, if I recall from your slide, JD, there was 7 studies total that were in that kind of implementation preparation and implementation phase. And when we look at kind of the landscape epidemiologically, the 90-90-90 testing, we're doing better and better. That number's getting smaller. Heidi Crane publishes in Annals with a nice editorial from Dr. Fauci about 90% suppression among those in care. And the real challenge, from an individual and population health level, is this retention piece. And at a point where we still have some basic challenges with measurement, I think the idea of loss to clinic, loss to care, as Elvin talked to. So how do we simultaneously have the science of retention? We have very few evidence-based interventions ready for dissemination, but clearly this is the area where there's the most margin in terms of enhancing population health outcomes. So just wondering, in thinking about the scientific portfolio, we have basic stuff on measurement that has to get done, while some discovery and intervention development, but we also want to think about strategies for implementation. So how do you see retention and care fitting in within the portfolio relative to some of the other areas on the continuum?
Chris, before you answer that, I'd like to hark back to a talk from this morning where really the take-home, I'm going to say, is about behavioral and socio-structural factors, where essentially with transgender population, transgender women, one of the barriers to care was transportation, was the fear of taking public transportation and potential violence. And I think in what you're bringing up, we have to include the socio-structural factors. We have to essentially know what that context is, and it really is beyond how are people being received once they walk into the clinic door. So I think to build on what you're saying, that it's actually a broad spectrum approach that's needed.
It's a great question, Mike. And in general, doing, retention and care work is difficult because by definition, you're trying to work with the patients that are most susceptible to loss. And so I hope this isn't too mushy of a response, but what we would encourage, and maybe it'd be good to articulate or try and write this out in some way, that retention and care work that we fund tries to do some of both at the same time. Now, I'm not sure whether that's a hybrid efficacy effectiveness trial, and we fund some of those in other areas, or an adaptive trial design, or I don't have a incredibly wise magical answer to that, but we are trying to be planful in the ways that we select projects to pay. And I would say on balance, there are more people who are still doing sort of discovery science and intervention development. And if we reach for something that may be more innovative or doing something, as you say, then we have to skip something else.
Any other questions? We have time for one more question.
Thank you. And thank you for your time today. I'm curious, this speaks a little bit to one of the points that was brought up by the health department about this research fatigue amongst subpopulations of individuals, but also thinking about the nature of implementation science and the burden that it can have on health systems, and what sort of scope there is within the funding mechanisms to allow for participatory phases, for real engagement with the health system to identify first what is really going on in this space. What are the things that we can learn from it? What are the things maybe that are already in the fridge? And what are the things that we definitely don't want to take out of the fridge? That if we intervene in this way, we may be causing harm to the system, which is maybe a harder thing to get to know and understand than an individual in some ways. Or maybe it's just something that we don't understand as well. So thinking about scope for, again, participation, involvement of these systems. And sometimes I wonder, in some sense, from an ethical perspective, if that's maybe not why we don't see some of the more innovative things in low and middle income countries, because maybe there's actually a lower bar to engagement, rightly or wrongly. So curious some reflections on that, and scope for including some real partner-based participatory engagement work prior to the implementation science pieces.
That's a really thoughtful question that I'll have to just briefly respond to, and we can talk more after because we're being told that we're out of time. We would encourage that kind of formative work, and we have mechanisms that can accommodate it. And I agree that the more tools that we are, the more thoughtful we have to be. Someone mentioned earlier about trying to think about doing mental health screening and treatment in STD clinics. I thought, that's great. That's a great idea. How's that going to happen? And so you're right. We need to be mindful of the system as we're trying to innovate. Which is great that a lot of the people in this room are clinician researchers who appreciate the challenges of doing research in a clinical space.
I know we're going to conclude, but I'm going to conclude with a boring tip for everybody, but maybe a useful one. As you do your submissions, the slides about the 5 overarching research priorities, 2 things. One, make sure if you're going after the AIDS funding, that you speak to those priorities because they're looked for. Number two, you don't have to pick just one priority. You can essentially say this study is going to relate to this priority, and these are the reasons why. And you can do that in a paragraph. It's easy. But just make sure it's in there. Thank you.
Well, thank you guys very much. And we're going to move on to the last part of our agenda, where we're going to hear case studies or, real examples of implementation projects.
Thank you so much to the last speakers. I'm actually going to ask our panelists to stay put for now because when you come up, you can't see anybody else's talk. So we'll bring you in at the end, but at this point, you can just stay put. I'm Lois Eldred. I oversee the clinical core for Center for AIDS Research, and I'm a co-director of one of the 4 co-directors of the Implementation Science Scientific Working Group. We have a fantastic panel this afternoon, and it's entitled, What Would You Do? Many case studies in implementation science, and the point is for it to be interactive. What we're going to try to do, see if we can do this, is I know that I believe that Ingrid has some interactive stuff in the middle of the presentation, which is fantastic, so we'll do that. We will work on having some what would you do question and answer after each case. If we find we're running out of time, we'll collapse it a little bit, but I think we can pull that off. I think we have enough time. So our first presenter, the other thing I want to say is it's just a really diverse group of cases. We have 2 from South Africa, 1 from sub-Saharan South Africa, and 1 from Alabama, which is just fantastic in terms of looking at implementation science methodology. Dr. Bassett is an associate professor of medicine at Harvard Medical School and infectious disease physician at Mass General. She is the director of the developmental core and of mentoring programs at the Harvard University CFAR. And she has over 14 years of experience leading clinical research in South Africa related to HIV and TB screening and management. Welcome, Ingrid.
Okay. Thanks very much. It's really a pleasure to be here. I'm going to be speaking about a policy shift in South Africa to the Central Chronic Medicine Dispensing and Distribution Program. That was named by the South African agency. It's very long. I'm going to call it CCMDD. We've recently gotten a notice of award and are gearing up to actually start the study. So this talk will focus on study design issues. And as mentioned, I will be posing some questions to you. So this is a roadmap of what I'm going to talk about. I'm just going to touch briefly on the big challenge of attrition from HIV treatment programs in South Africa. Then I'm going to talk about the opportunity to study this policy change for ART distribution. And then I'm going to pose 2 questions to you about potential ways to design a study about this policy change. The first will be a best case, and the second will be the reality scenario. And finally, I'll just summarize briefly our plans for the study at the end. So one of the big challenges in South Africa and other high-burden settings is attrition from public sector HIV clinic sites. The South African public sector clinics are really congested, and this photo here of a crowded waiting room where people can wait all day to be seen is a familiar one. One of the reasons for this is staff shortages, particularly in South Africa, where the majority of healthcare workers are actually in the private sector. And this leads to long queues and issues with quality, which are key drivers of attrition for people on antiretrovirals, with only 2/3 of people who start antiretroviral therapy remaining in care at 5 years. Some strategies which have been tried to increase retention and decrease clinic congestion have tried to take care outside of the brick and mortar healthcare system for people that are chronic and stable with their medications. These include things like home-based services, community adherence clubs, self-forming community groups. And a recent meta-analysis of community-based interventions like these found that people do as well in terms of ART adherence, in terms of virologic suppression and all-cause mortality, when comparing these community versus facility-based interventions. So this is great. One potential problem, though, with these strategies is that they're quite resource-intensive, in part because of the adherence and social support that's provided by nurses, community health workers, and treatment supporters who are often acting as extensions of the clinics. So that really brings us to the motivating question of the program change in South Africa. Would community pickup points without adherence support, so for example, having people pick up their medications in churches or other community venues without an additional intervention for both ART and for non-communicable disease treatment, be effective? In other words, would picking up medications in the community without adherence support, as opposed to in the clinic, lead to similar rates of virologic suppression? I think there are many potential pros and cons to an approach like this. Some pros are that, the community-based pickup points may be more convenient for the patients. The intention, certainly from the South African government perspective, is that it would decongest clinics and allow them to really focus on people who are ill or those who are initiating therapy. And because there isn't a support component, it may be easier to scale up. Some of the cons are that, less adherence support may translate into less adherence. There are fewer opportunities to identify potential adverse events or opportunistic infections because there are fewer clinical contacts. And it may be easier to fall through the cracks if someone doesn't make it to a community pickup point to pick up their medications. So that brings us to this Central Chronic Medicine Dispensing and Distribution, or CCMDD, program change in South Africa. The goal is really to improve access to ART and other chronic medications, and it's part of a broader initiative in South Africa to improve care in the public sector. So stable patients, which they deem virologically suppressed at 1 year, and people stable on their non-communicable disease medications are eligible to participate in this program. This is a kind of simplified schematic. Basically, if the patient comes to clinic and is deemed eligible to participate in CCMDD, a specific kind of prescription is written, and that's sent to MediPost, which is who the KwaZulu-Natal Provincial Department of Health contracts with. They package the medications and deliver the drugs to the pickup points on the far right. And they also send an SMS to the patient to let them know, your drugs are available at the church and ready to be picked up. And the patient then goes to the pickup point to get the medication. If the patient doesn't make it to the pickup point and the drugs are left behind, then you can see the dash lines. The drugs are supposed to be returned to MediPost. MediPost is supposed to notify the clinic of defaulter notification. This patient didn't make it, so that the clinic could use their defaulter tracing mechanisms to try to find the patient. And so this is really what the program looks like, somewhat simplified. And the goal is that not only can people pick up medication outside of the clinic, but the pickup is less frequent. So they go to these pickup points every 2 months as opposed to coming every month to the clinic. And patients are only seen in clinic every 6 months for a prescription renewal and for clinical assessment. Okay, so that brings us to the first question. You are asked by the Department of Health to evaluate the individual clinic and community level impacts of the CCMDD program before the policy change is adopted in 10 public sector clinic sites in Umlazi Township, which is the largest township south of Durban. And the Department of Health tells you, look, all the clinics eventually need to implement this program, eventually, but the timing of that is to be determined in terms of the specific clinics. So how might you design a study to evaluate the CCMDD program? Don't be shy. Dick, you're smiling, so I'm tempted just to call on you. Oh, wait, no, JD, okay.
Oh, sure.
You saw a hand?
Yeah.
Shy hand?
I would do a randomized implementation rollout trial.
Okay.
Do a within and between comparison, and I would match sites based on different characteristics, but timing would be the way in which they're randomized for implementation.
Great. Any other options? I think that's certainly one good one. Yeah?
But you need to ask yourself, do you need to essentially do the prep work or formative research of geospatial mapping of what centers are churches even willing to be set up as these sites before you take on the big enchilada, so to speak? How do you know your communities? Do you know what preparation is going to be needed? What are your numbers? Approach it as a business model as well as a socio-structural model.
Lovely. All right. I hope we have time to come back to that at the end, because I'm not sure that really happened when we get to the reality scenario. Please.
I think one of the things you need to do is you need to survey the patients themselves to see how they feel about confidentiality and their issues about picking them up in community sites versus clinic.
Mm-hmm.
Just as a design comment, that this is one of those ones where eventually everybody's going to implement, and you have to start somewhere. So a step wedge is often, a way to do that, although analytically challenging. And I think the lesson I've learned from David Dowdy is don't try this at home. But still.
Okay, that's. Oh, do you have another comment?
No, I'm the
Please.
mic.
Oh, okay.
Rover.
Well, that's just too good of a transition to let it go. Okay, so. So in the ideal scenario, having an opportunity to randomize patients or clinics or communities, as has been mentioned, would lead to, we think, more robust results. And one possible strategy would be a step wedge design, I think, especially if you're doing this across more clinics or across more communities. Just to say briefly a little bit about this, all the clusters or clinics start off in the control, shown in the lighter purple color, and they all eventually cross over into the intervention, shown in the darker blue color, but the timing of the crossover is what's randomly assigned until all the clinics have ultimately received the intervention, as on the far right. And then outcomes are measured at all of these different randomization time points. And I think this technique is increasingly popular for evaluating service delivery and public policy interventions. And I think it allows for randomizations, but also all the clusters get the intervention eventually. And I think that's more palatable to the communities and to the departments of health often. And I also think it's the way that programs are actually rolled out. Not every clinic starts it all at once on the same day. So I think it kind of takes advantage of that. There are definitely issues about size of cluster and power, and don't try this at home, or at least not without a good biostatistician would be my suggestion. But I think also dealing with temporal trends is a consideration because more people are receiving the intervention later, and so that's also something that you have to think about in this design. But I think still would be a very promising design, but unfortunately, this was not the opportunity that came our way. We were unable to randomize. It would have been really great if the Department of Health had approached us before they implemented the policies, that we might have had a chance to do something like this, but they didn't. Alvin.
Sorry, I don't know if this comment you can go on, but I think you brought up a lot of the caveats of step wedge. There's just for people who are interested in step wedge. I'm not a step wedge hater, but there's an issue of the Journal of Clinical Epidemiology sort of dedicated all the articles about why you should never do a step wedge, and there are some trials. It's in trials. It's in JCE. Oh, okay. Well, maybe there's another one.
I think I stole the figure from them. Yeah.
so it's just like there are.
Lots of issues.
But so natural experiments are another way to potentially approach this. But
great, thank you. Okay, no, this is good. It was the risk of posing the questions. Thank you. That's very helpful. So this brings us to the reality scenario. So in this reality scenario, this is more like what happened to me, which is in this case, you approached the Department of Health about evaluating the individual clinic and community level impacts of the CCMDD program. In fact, after adoption of the policy in the 10 clinics in Umlazi. And what you learn from informal visits to these clinics is that the clinics are saying about 20% of people who are eligible to participate in the CCMDD program are actually declining participation in the program. So now, how might you design the study? In other words, how can you compare? Can you compare CCMDD enrollees to non-enrollees without randomizing? Is there still a way to try to show that people enrolled in CCMDD are doing as well or better than people not enrolled in CCMDD? JD, I see your hand.
Either way, doesn't matter. So one thing is, from a design perspective, I would be actually really curious about the definition and evaluation of adoption. The fact that the policy's been in place and they say they're doing it does not mean they're actually doing it. So an evaluation of fidelity and penetration within those clinics is actually probably as much or more relevant than the eligible patient declining participation, but they're both relevant.
Great. Wait.
Sorry, I was just going to add on to that. I think that's critically important. There's also, a lot of times you can ask the question of what's the effect of availability on a population, and a separate question is what's the effect of what's the effect of the intervention among those who take it up? And that latter question is oftentimes very difficult to get at because the people who take it up and the people who don't are fundamentally different in ways that are unmeasured. And so an instrumental variable approach is something that can take a stab at that latter question.
Great, thank you. I think there were some questions here, Michael, yeah.
Just building off of Elvin's idea, if you had access to like a robust electronic medical record where you could follow those patients and identify who took the intervention and who didn't, and maybe do some propensity score matching to try to get to those differences between those who accept the intervention and those who don't, and maybe a random sample of individuals who get surveyed on some of the behavioral factors as well, you could try to get a sort of cheap, routinized evaluation as it rolls out, and do it as a sort of prospective cohort with mixed methods. Thanks.
My God, I didn't plant him.
I think similarly to what Elvin was saying earlier, which is clear, is that you can do, the time of intervention, that's the moment in time. You can look at an immediate before and after, and that controls for many of the historical time and other factors. So you can do that. You can do kind of a series. So you can do that, and then you can do looking at those that adopted and look at them 3 month and 6 month and see retention and compare retention. So there's a series of comparisons that you could do that would get at the whole, I think.
Great, thank you. So I just want to expand a little bit on what was said in thinking about how to use observational non-randomized data to evaluate treatment effects. So propensity score matching is one potential way. We know that treatment selection, or in this case, participation in the CCMDD program, may be influenced by participant characteristics, who takes it up and who doesn't. In other words, like these baseline characteristics of these people who are CCMDD enrollees on the left may differ systematically from those who are not CCMDD enrollees on the right. So in this case, we'd be trying to match CCMDD participants to non-enrollees based on a set of pre-treatment variables that we would try to collect. And so here in this example, you see the person in orange who's a CCMDD participant or in the treatment being matched to non-CCMDD participants who have similar baseline characteristics. And the idea is that if we can find robust control group matches, we can try to overcome or at least reduce confounding bias when estimating CCMDD effects. And if you're approaching the Department of Health after it's already going on, this may be what's in the fridge. Okay, so just to say briefly, I couldn't come here without, putting up, I'm even afraid, is this a framework? But anyway, maybe JD will comment in some way. But we are grounding our evaluation in the Practical, Robust Implementation and Sustainability Model, or PRISM. And this model was really developed to try to help identify and assess the contextual factors and influences, such as intervention design, external environment, implementation and sustainability, infrastructure, and the participants, the recipients themselves, and how they influence program adoption, implementation, and maintenance. And so you can see the re-aim dimensions are shown in green at the bottom and are used to evaluate program effects. So for me, this was a way to try to organize the structure of the program, what the clinics themselves had in terms of implementation, sustainability, infrastructure, what the external environment was with respect to the Department of Health and the pickup points, and then also the patients as the recipients. So just to summarize briefly what we're actually planning to do, in AIM 1, we will be doing a patient-level assessment via a cohort study, enrolling patients eligible for CCMDD at these 10 clinics, both those who agree and those who decline participation in the CCMDD program. And as discussed, we'll be using the propensity score matching technique to try to estimate the average treatment effect of CCMDD on 12-month virologic suppression. And here we're really interested in, at the patient level, what factors influence uptake and outcomes in CCMDD. And so some examples or some of what we're thinking about in terms of hypotheses is like, does receipt of concurrent non-communicable disease treatment in addition to HIV treatment affect outcomes here? Or does the fact that there's no contraception in the CCMDD program affect the uptake and the outcomes for women who are eligible to participate in it? In AIM 2, we're really going to try to be thinking more at the clinic level using a mixed methods approach with interviews with frontline providers, pickup point staff, the staff at MediPost, as well as focus groups with patients who both agree to participate in CCMDD and those who decline. And here we're really trying to think about these facilitators and barriers to adoption by the patients, but also by the clinics. Like, what are the organizational characteristics that lead to successful adoption of CCMDD? And things like organizational capacity and readiness, what mechanisms are in place to coordinate with MediPost and the pickup points, whether there's existing infrastructure in the clinics that can be used to try to implement CCMDD. We're hoping also the qualitative work will really help us get at the heterogeneity in CCMDD implementation in the clinics, because at the sort of implementation and adoption at the clinics, because just from my own kind of visits and observations, they're quite heterogeneous in terms of how they're handling this, and we're hoping we'll be able to get at that through the mixed methods, and that also the qualitative will help complement the quantitative results from AIM-1. And then finally, we are trying to think at the community level, so not just people enrolled in our cohort, but trying to use electronic health record data for all the HIV patients in these 10 sites. Really trying to understand, does CCMDD expansion lead to higher numbers of people being virologically suppressed, which is the hope, or does it need to lead to more people being lost to follow-up, also known as no known outcome? And here we want to see whether there are clinic factors, the size of the clinic, how well they're doing with CCMDD implementation. How does this influence the outcomes at the community level? We'll also be looking at the change in proportion of people who enroll over time and whether the enrollee characteristics change over time. I don't want to go through this in detail, just to say that we kind of mapped back these ideas onto the RE-AIM framework to be able to measure our patient-level outcomes, our clinic-level outcomes, and also really trying to think from the maintenance perspective, even at the community level. So to conclude, attrition from care for people chronically on antiretrovirals remains a major barrier for achieving the UNAIDS 90-90-90 targets in South Africa. I think it requires innovative solutions to try to meet the increasing demands on the public sector, created both by test and treat and by the rise in non-communicable diseases. Decentralized medication dispensing, like the CCMDD program, I think has the potential to offer more convenient services and decongest clinics. And we are happy to have the opportunity to use observational data and the implementation science framework to be able to evaluate this community-based program. We hope this is going to inform the South African Department of Health about how to move the program forward, and also other high HIV burden settings. I'd really like to thank the CCMDD study team and also our funders. Thank you, Chris. And I'm happy to take any questions. Thanks.
Thanks, Ingrid, for sharing this new upcoming study with us. Before I saw your AIM-3, I kind of was thinking about this as like a non-inferiority design, that you were going to try to show that this new approach would not result in worse outcomes. But in fact, you're hypothesizing, I think, that it's going to result in better outcomes. And how did that play into your thinking about the design?
Yeah, I mean, I think with the patient-level cohort, I think our goal is really to say people can do as well. I would be surprised if people do better. So I do think we're thinking in the non-inferiority way. I think with the community-based outcomes, we wanted to get a little bit more, not so much at the individual patient outcomes, but more at the effects of CCMDD expansion. So, as a greater proportion of the population is enrolled in CCMDD, what does that do at the community level to the proportion of people who are virologically suppressed? And so I think it's like we're trying to ask slightly different questions in the two aims. But yeah, I'm hoping, it can be as good. I think if we can show that CCMDD people do as well as, what has been seen in these more intensive interventions in the community, that I think would be good news.
I have a somewhat of a suggestion that I'm going to try to mask as a question. Where do you see in the aims a consideration about variability in type, amount, and fidelity to implementation strategies themselves?
Yeah. Okay, so maybe I should go back to the land of RE-AIM. I didn't really get too much here into what we were doing for adoption and implementation, but part of what we want to do with implementation is try to characterize the clinics as like low, medium, and high performers, really trying to base that on the extent to which, what proportion of eligible participants are actually enrolled. So I think, we're trying to understand, I think one of the things I see is that they implement this in different ways. So some clinics, I think, have much better systems than others. So, for example, one of the clinics, really identifies people in advance. They know who's coming tomorrow, which is already like, whoa. And they pull the files and they decide these are the people that are eligible. And so I think, unfortunately, not all clinics do that. So it's even hard to know what we're measuring fidelity to, because the actual SOPs, or sort of the guidelines for CCMDD from the government, they give some general guidance, but there's not really like, this is the standard set of things the clinic has to do to implement this. So it's hard to measure against something, but we thought we would try to characterize these sort of low, medium, and high performers and see if we could figure out what are the characteristics of each of those as a way of being able to disseminate best practices from clinic to clinic.
So
You can come talk to me later, though. I'm looking for. I always love it. I haven't done it yet,
offline.
so like, there's still time. There's still time.
Thank you so much. Thank you.
Thank you.
Dr. Vick.
Thank you.
Fantastic. Okay. Moving right along, I think what we'll do at this point is, I think we'll just go ahead and have the rest of the presentations and have some time for a group discussion at the end. It was a nice thought, but Dr. Michael Mugavera is a professor of medicine and co-director of the University of Alabama at Birmingham Center for AIDS Research. His HIV-related research program was centered around a status-neutral HIV care continuum with particular focus on re-engagement in care and promotion of health equity for individuals, communications, and populations. He is a medical provider at the UAB 1917 clinic and participates in numerous local, statewide, and regional efforts towards ending the epidemic in the U.S. Deep South. Welcome.
Great, thank you. So thanks for the introduction. I want to first thank Larry, the entire team that organized the symposium. It's really wonderful to see it's the 5th year, really great to be here. So thank you for putting this together and for the invitation. I also want to thank the Inter-CFAR working group. So we're going to meet tomorrow, but the leadership from Steph, I've learned so much from you this last year, as well as Nanette and Brian Mustansky, who I think can't be here. But it's really been a wonderful journey for me as someone that doesn't, as I attested to in the first meeting, consider myself a card-carrying implementation scientist, to be around this group and learn quite a lot from this group. So I hope through this case to get some feedback and examples. So I'm someone who's trained in health services outcomes research that has spanned quality improvement and kind of really this continuum of implementation science. So I'm going to describe a project that we're working on that was not developed specifically with an IS lens or framework or measures, but I think with a little bit of feedback and help could kind of move into that space or adopt some of those principles, perhaps as a preparatory study in that kind of scoping review towards doing something that's more formally in that IS space. So Data for Care Alabama, clinic-wide risk stratification, retention, and care strategy. So the first thing I will note is, and I might have messed it up, JD, I used to have intervention here back in March, and I changed it to strategy, and I might be using those terms completely wrong. And I'm totally open to being told that you totally screwed it up, and that's totally cool. I got thick skin. So just to give some perspective on HIV in Alabama, where I live and practice, statewide, kind of our care continuum, 2017 preliminary data, each of those little images of people is 50 persons. There's roughly 16,000 persons estimated to be living with HIV from surveillance data. Among those, over 13,000 individuals are diagnosed. In 2017, around 9,500 received care, and a majority of those receiving care were virally suppressed, so 7,200 individuals. So large gaps in terms of viral suppression relative to the overall population living with HIV. And as my question to Chris and earlier comments spoke to, that really large group of individuals who are diagnosed and not in care or received any care as the great opportunity for us to improve outcomes at an individual and population level by enhancing viral suppression. So as a way of background, improving retention and care, in my opinion, is the greatest opportunity we have on the care continuum to really advance prevention and treatment benefits for persons living with HIV. In contrast to linkage to care, where we have big programs like ARTIS, and re-engagement in care, where there's programs like Data to Care, so using surveillance data to map with clinics to see who's out of care, try to get at this lost to clinic, lost to care conundrum, and then intervene. There really aren't, to my knowledge, domestically large-scale programs that have been implemented for retention and care. Speaking to those cross-agency partnerships, the Ryan White HIV AIDS program administered by HRSA offers a systematic program opportunity to have clinic-wide retention and care programs. So the Ryan White structure, you have clinics that are supported by HRSA that really gives you this network to try to develop and implement intervention systematically. So in terms of data for care, so a distinction from data to care, the big picture of what we propose to do starts with risk stratification. So looking at individuals living with HIV who are in care and trying to identify them as low risk, medium risk, or high risk based upon one simple variable, the number of missed clinic visits they had in the previous 12 months. Then we have resource allocation. So we're taking this retention through enhanced personal contact, which is one of very few evidence-based efficacious interventions, and delivering it to those individuals who are intermediate and high risk. So the low risk folks don't get any additional resources. The other part of this was in each clinic, whichever resources they have for retention and care should go to the high-risk individuals. So the distinction between intermediate risk and high risk is your high-risk folks get whatever else that you have beyond that retention and care, not prescriptive. It might be patient navigators, it might be peer mentors, it might be case management, whatever that case may be for your high-risk folks. And we frame this in a continuous quality improvement lens. So again, the lines between quality improvement, health services research, implementation science in my world are very blurred. And depending on the purpose, the funding agency, the sponsor, you might frame it differently, but the reality is a lot of it for me is on a lot of gray and not very distinct silos in those areas. So this idea of an iterative process at a clinic-wide and individual level to monitor, do risk stratification, and target risk service delivery. So the idea is working within clinics, and most clinics have quality improvement as part of their core values and what they do. Can this data for care strategy or intervention, you'll tell me which one it is, become part of a quality improvement program that just becomes part of the fabric of providing care? So again, in terms of risk stratification, very, very simple. It's just based upon missed primary care visits in the prior 12 months. Individuals who miss 0 visits would be low risk. Intermediate risk would be 1 or 2 missed visits, and high risk would be greater than or equal to 3 missed visits. And so the process is you'd have a data manager at a clinic, and all these clinics have data managers. They're reporting to Ryan White regularly. Would do the stratification at some periodicity, be it monthly, quarterly, but would identify your low, medium, high risks, and then match with the clinic schedule. So you'd say in the next 3 months, here are the individuals who are coming in who are intermediate and high risk, and those are the folks who would get that evidence-based intervention. And so why focused on missed visits? And I think this is because many reasons, a lot of epi work on this, won't go into great detail, but did a systematic review recently demonstrating missed visits pervasive globally, consistently associated with increased mortality risk, lack of viral suppression, viral resistance, risk behaviors, you name it. The critical thing about missed visits versus other measures of retention and care is it's easy to measure at a clinic level. Really only clinics can measure it, and in real time. So in contrast to some of the other measures of retention and care where you have to wait a year or wait 2 years and say, was someone retained or not retained? In real time, you can know if someone missed a visit and act upon it. So really is valuable. The other key thing about this, and I think there's importance to these kind of measures based upon surveillance with viral load as a proxy for retention and care, but only clinics typically, in some states like New York, they get missed visits, but at the clinic level, you can capture this, this in real time, you can do something about it. So I think retention and care is uniquely something that has to be grounded in the clinic, working with community and public health partners, but retention interventions have to start at the point of care at the clinic. So my colleague Brian Pence did this study in Phoenix. There's 8 CFAR sites, including Johns Hopkins, among others, looking at 10,000 persons living with HIV, over 100,000 visits, and asked a simple question about missed visits in the previous 12 months, according to this risk stratification. And what he found was that half of the population, so 50%, had missed no visits in the prior 12 months, and their no-show risk for the next appointment was 9%. And they accounted for about a quarter of all missed visits that subsequently happened. 35% of the clinic population had 1 or 2 missed visits and would fall into the intermediate category. Their risk of missing the next appointment was 22%, and they accounted for 43% of all subsequent no-shows. And there was 15% of the clinic population that had 3 or more missed visits. their risk of no-show bumped up to 35%, and they accounted for 30% of all no-shows. So this is just kind of looking at the idea of looking at a population of patients clinic-wide. Roughly half of your patients would fall into low risk, would require no intervention. You'd leave them alone. The remaining half of patients would get this evidence-based intervention, with only 15% really, if they weren't already getting it, getting those best resources that currently exist and are available in your clinic. So we'll not go into great detail, but this is the evidence-based intervention proven through a randomized controlled trial at 6 different sites, including Johns Hopkins and UAB. And it was a pretty simple strategy or intervention approach of enhanced personal contact. So personal reminder calls 6 to 8 days before a visit, 1 to 3 days before a visit, and within 48 hours of a missed visit. So this enhanced personal contact, same person making these calls, making this communication, and is one of very few evidence-based interventions that exist for retention and care. To my knowledge, no effectiveness trial, so it's purely based upon an efficacy study, but this is kind of the evidence and the intervention we were looking at. And in terms of the intervention itself and some of the outcomes, there was a 10% increase in retention and care by a constancy in the HRSA-HAB measure, a 5% increase based upon visit adherence. There were some skill modules that were done. It was brief, didn't show any added value beyond the personal contact, so no need for the extra piece of the skill modules. Importantly, it was efficacious in women, African Americans, and those with low SES as measured by private insurance. Also a dose-response relationship in terms of the number of contacts and retention in care, and there could be some confounding there. Was not efficacious in those with unmet needs and illicit drug use. So speaking to context, other things, this is not going to work for everybody, but a fairly simple intervention can be done at low cost. The Shritha paper there was actually a cost analysis done by CDC of this intervention that showed some efficacy. So your high-risk patients, as I mentioned, also get the high-intensity interventions, and importantly, low-risk patients, still 9% miss that next visit. So if they miss, have a system of tracking, making that missed visit call, and then transitioning to intermediate risk for future proactive reminders. So the whole idea of risk stratifying, proactively avoiding missed visit. If someone's low risk and they miss, reactively kind of getting them and trying to get them back in before they're totally lost to care. So even with Elvin's caveat of fear, the step wedge design, when we talked about this, we're still in the strategy was to do this non-randomized step wedge trial. And this is ongoing now. So we're doing this in Alabama with 7 different clinics that are connected through a quality group. And we're looking at data that are both individual level as well as clinic-wide sociodemographic lab and visit data that mirror the RSR. So RSR is a Ryan White reporting system. Every clinic reports client-level data to HRSA on a regular basis. So rather than recreate the wheel, our data dictionary is based specifically on the RSR. So that's kind of what's in the fridge, but then adding some other things in terms of going to Whole Foods or somewhere else to kind of get some extra data elements and measures, and both process and outcomes metrics. So the Alabama Regional Quality Group is a group of these, there's 9 clinics total, there's 8 shown here, and have been meeting around quality quarterly for many, many years now, over a decade. And with our involvement, added a missed visit indicator or a no-show percentage indicator, and this is just clinic-wide data. So this is not individual level, but clinic-wide data showing, missed visits are very common, clinic-wide no-show rates ranging from 18 to 32%. So a lot of buy-in from this group that has been meeting for a while saying, we're tracking these data, but what are we doing about it? And this was our opportunity to actually develop a study and do something about it. And again, as I mentioned, using this PDSA cycle, so it was kind of framed within a CQI framework of plan. We're doing centralized and on-site trainings and refreshers for all of these different sites as we roll out. There's a structural level clinic-wide risk stratification plus the individual level intervention for the intermediate and high-risk patients, quarterly data reporting, program evaluation, plan to give feedback reports to clinics as part of the process, and then to kind of review this quarterly in terms of quality improvement outcomes for the project goals, which I didn't share, and to modify the work plan as we need, with the UAB CFAR providing the research engine for this, and that quality group, that real clinical engine that's driving it and providing the foundation and the data and the resources. So in terms of what we plan to measure process-wise, and again, this wasn't designed within CFR, REAIM, any IS framework. This was designed more as an effectiveness trial. I think it's really more of a hybrid type 2 or 3, IS study, but want to look at the fidelity of clinic-wide risk stratification. So, can clinics do this low, medium, and high, and how effectively do they do it? We had our first pass at this where clinics generated data looked remarkably similar to Brian Pence's Scenics data. About half of patients are low risk, a third are intermediate risk, and 15% are high risk. The fidelity of the reminder and missed visit calls. So there's a clear protocol and structure, so capturing are sites doing this, are they doing it according to the prescribed schedule for the right people? Measuring what are the best retention and care programs for each of the sites. So want to capture what is it. It's going to vary by sites. Didn't want to be prescriptive, want it to be more pragmatic in terms of what they're doing, not adding no new FTEs, no new resources, but knowing what is it that is the best high intensity interventions, and what is the fidelity of patients receiving that. So is the 15% of folks that are high risk, are they getting whatever you tell us is your best available resources? And then for outcomes, we're focusing individual level and clinic-wide on missed visits, visit adherence, and the HRSA-HAB as measures of retention, as well as viral suppression. And I don't think we're going to touch viral suppression because it's at 90%. So I think the reality is, and this is a challenge in this field, the goal is to include more folks who are in care and it's sustain that 90%. Right? I mean, we're not going to bump up a ceiling of 90% in suppression, but the hope is by doing this intervention, by proactively acting on missed visits, reacting to the missed visits, we can kind of get more people that are sustained in care over time while sustaining 90% suppression and having individual population level impact. And then my question, maybe if we have time later, is how do we enhance this? So I'm not a card carrying IS guy, but I really believe that there's a lot of opportunity for folks like me to do this kind of work with some adaptation, with some, training and some feedback. So how does a study like this move from being more of an effectiveness, health services outcome CQI project to being a bona fide IS study? Thank you. And acknowledge CFAR folks.
Dr. Michael Hurst is an assistant professor at University of North Carolina, trained in infectious disease. And looking at his resume, I think he gets the prize in the room for going to graduating from the most Ivy League colleges that do not include Johns Hopkins. He has an impressive resume. He is an active implementation science researcher and is the director of implementation science for the Center of Infectious Disease Research, CIDRS, in Zambia. Current research interests include evaluating clinical outcomes and the operational feasibility of universal test and treat approaches to HIV care and prevention in Zambia and South African prisons, understanding post-release clinical outcomes and barriers to and facilitators of HIV care engagement for HIV-infected ex-offenders in Zambia, evaluating the effects of expert MTB RIF on access to tuberculosis treatment and patient health outcomes for people living with HIV under routine programmatic conditions in Zambia. And I'm going to stop there. Could go on, but we'll just stop there and welcome Michael.
Thanks so much. So I just wanted to thank Elvin Gang for connecting me to the CFAR group and Steph and Larry for inviting me. And I apologize if I'm really jet lagged. Fortunately, Chris Hoffman is a co-investigator, so he can fill in where I get things wrong. So I'm going to talk a little bit today about retrofitting implementation science. I think this has been a theme that's come up a little bit. And thinking about applying implementation science frameworks retrospectively to better characterize implementation of a treat-all intervention in Southern African correctional facilities. But first, I wanted to thank my collaborators and colleagues, including partners from the Zambian Correctional Service and the Correctional Service Department in South Africa, as well as Salome Charlambus, who's the overall PI with the Orm Institute, and Christopher Hoffman, who's been a wonderful colleague and mentor on this project. So I'm going to start by just going over the study question and aims for our initially dubbed Treatment as Prevention in Prisons study, and then talk a little bit about our intervention and study overview. And I have to say, in full disclosure, I'm the director of implementation science at CIDRS, mostly based on enthusiasm and less based on experience. So please feel free to correct me as we go along. I'm going to present some hot off the presses results that are mostly descriptive and that follow a re-aim framework. And then I'm going to try to spend some time prompting discussion about how to use qualitative and survey data to really characterize the implementation, adoption, and maintenance of an intervention and its strategy in full disclosure, we started with an interest in examining those things really from a thematic analysis, inductive health system-based approach, as opposed to using a formal, tried and true implementation science framework. But you'll see that I think a lot of the concepts are comparable and can be mapped, but I will raise a couple issues that arise that I think defy construct. So I'd be curious to hear what people think about which framework to use. So our primary research question is universal test and treat treatment as prevention a feasible strategy to prevent HIV transmission and increase access to HIV treatment and coordinate the TB care continuum in correctional facilities in Zambia and South Africa? And I know implementation science is concerned with the delivery of services in real-world settings, but as you'll see, it doesn't get much more real-world than a prison or correctional facility in Southern Africa. So, and to that point, I think we were awarded funding from the Evidence for HIV Prevention Southern Africa Fund, and as our study monitor has said, the fact that we even completed the study was a testament alone. So they were just happy to see some results, so that speaks a little bit more to the real-world conditions where we were operating in. But we primarily had 4 aims that were patterned around the RE-AIM framework. And essentially, the first aim was really concerned with reach and effectiveness of our intervention. And the second and fourth aims were designed to understand individual and facility level adoption, implementation, and maintenance of our intervention after introduction. And then given the centrality of cost to all implementation and maintenance, the third aim incorporates a costing analysis and a description of programmatic inputs. So this is an overview of our test-all intervention, and it's basically modeled around WHO guidance from 2015, which in the study countries, and particularly in correctional facilities, was not routine care until well into 2016 in Zambia and middle of 2017. And even now, there's no policy guidance that extends universal test and treat into prisons in Zambia. So it's not a mandate. But this is generally, as we know from START and other trials, that this is tried and true to evidence-based intervention. Our intervention, though, was adapted to the prison context, and unfortunately we didn't do the pre-implementation sort of formative work to adapt it. And I really sympathize with one of the speakers who said that, you know, embedded in the program like I am, we have a $100 million PEPFAR program, we don't often have the luxury of doing things stepwise. I think the expectation, as you'll see, is HIV prevalence in correctional facilities in Zambia and in South Africa over 20%. There's a paucity of services. To kind of deliver and also measure is sort of an imperative. I don't think we can always do it sequentially as we would like. But essentially, intervention involved universal TB and HIV screening for all inmates at entry, routinized periodic HIV and TB screening thereafter, systematic identification of HIV positive inmates not yet on ART, offering immediate ART, which we tried to define as within 48 hours of diagnosis, enhancing or identification, enhancing follow-up typically through monthly clinical monitoring and viral load ascertainment every 6 months, and providing treatment support through task-shared peer educator services. And all these components were embedded within a larger leadership engagement and health system strengthening approach. And although we were not explicitly driven by a formal theory-driven strategy, we deployed 2 principal implementation strategies to deliver our intervention that varied by country. And I think this was by having a rich contextual understanding of the implementation climate in each setting. So in Zambia, where there's just a dearth of human resources for health in general, and then particularly in correctional settings. So there's about 19,000 corrections inmates in Zambia, and dedicated health workers, there are about 60, of which CITERS has sort of trained or prompted training for the majority. We decided that we would have a clinical implementation team that would be at the site and deliver the intervention. And in South Africa, where the prison health system was comparatively better resourced, our strategy was more of clinical support and mentorship. So our study essentially, it started in June 2016, extended through March 2018, and was conducted in 3 sites, Lusaka Central Correctional Facility, Johannesburg Correctional Facility, and the Breed Valley Correctional Complex, in 3 geographically distinct and demographically distinct areas of Southern Africa. I should say that each of these facilities are large correctional facilities. They have a lot of turnover. In South Africa, you know, it can be expected that about 2% of all adult males pass through a correctional facility in a year. So you can imagine the volume and the turnover at these sites. We essentially opted for an observational cohort study with mixed methods that involved the following components. So we had a prospective cohort, a virtual cross-sectional survey that was measured against 90-90-90 indicators, a qualitative in-depth interview analysis, and a costing analysis. And essentially, components 1 and 2 were focused really on adoption, reach, and effectiveness. As I mentioned, the qualitative component was trying to understand maintenance, implementation, and adoption, and the costing analysis, obviously cost. We had a variety of study populations, but in the cohort, we enrolled nearly 1,000 inmates living with HIV. For a cross-sectional study, we had about 1,500 inmates at baseline and another near 1,400 at endline in Zambia. We're still doing the data cleaning for South Africa, so we don't have that virtual cross-sectional data to present just yet. We did in-depth interviews with 50 inmates and 17 stakeholders, which comprised healthcare workers, managers, both from the corrections and the health side, as well as policymakers. And then we did a costing analysis with a structured survey involving 107 government health and corrections staff personnel. We were interested in viral suppression and retention in care as our primary measures of effectiveness. And then we did formally examine a priori implementation outcomes of feasibility, reach, adoption, fidelity, implementation, cost, and maintenance. So I'm going to go into some of the preliminary findings. So you can get a little bit more of a flavor for the population. Among the 977 participants who consented to take part in the cohort, we had 46% that were enrolled in Johannesburg, 43% in Lusaka, and 11% in Breed Valley in the Western Cape. The majority were male, young, had been incarcerated for less than 6 months at enrollment, and had a history of previous incarceration in among a third, and nearly half had never been married. In terms of trying to understand the reach of our intervention, we were able to demonstrate that 96% of eligible participants consented to be followed in the cohort, and that 86% of consenting participants agreed to immediate ART initiation. But due to high rates of interfacility transfer and release, viral load monitoring at 6 and 12 months was suboptimal at under 50% in both cases. And this was primarily due to the fact that nearly 50% of all the participants left the correctional facility by 6 months post-enrollment. But nevertheless, these findings demonstrate that there was a reasonable reach of the intervention within the overall population of those identified as HIV infected, as well as reasonable acceptance of ART. And in terms of time to starting ART, we noted that there was generally rapid ART initiation within 2 weeks, but there was tremendous site variability. So you could see in Zambia that essentially every inmate started ART sort of same day. At the sites in South Africa, the median time ranged between 8 to 14 days. So some of the implementation qualitative work that I'll present shortly will kind of touch upon some of that. And in terms of our primary measure of effectiveness, viral suppression, we were able to demonstrate that for inmates who were still incarcerated at 6 months, and we were able to ascertain a viral load, that over 91% were able to achieve viral suppression at a threshold of 1,000 copies per ml. And that seemed to be comparable across sites. For our virtual 90-90-90 cross-sectional survey, we have results here from Zambia. And so we use this to try to ascertain reach and effectiveness of our intervention outside of the cohort to kind of capture a more generalizable population within the entire correctional facility population in the year preceding the startup of the study, which was June 30th, 2016, and then in the year preceding the end of enrollment, which was exposed to the intervention, which was all of calendar year 2017. And we did this by leveraging routine electronic data collection systems. So in South Africa, we have Tier.net. And in Zambia, we have SmartCare. They have its limitations, but this allowed us to assess, I apologize for the Mac to PC conversion, which seems, and it's even worse because it was a Zambian Mac to Baltimore PC. But so essentially, I don't know if we have a pointer here. So at the baseline, so we had, the pointer's not working either. Is this working? Not very well. How about this? Sweet. Among 1,467 inmates who were incarcerated on June 30th, 2016, looking back 1 year, the proportion who knew their status, which was not a traditional 90-90-90 UNAIDS definition, it was ascertained by those with a test result that was documented within the past 12 months, so it's a proxy, this was 58.4%. And with a reasonably comparable population, by end line, this had increased to 92.2%. So with the intervention, we were able to show that many more individuals were able to know their status. Here, for ART uptake, this percentage is supposed to be 67.9%. And in the end line evaluation, it was 67.7%. So there wasn't a change in the proportion, but the absolute number increased. And I'll draw your attention to the 386 individuals who did not know their status, of whom we could assume that a substantial proportion were HIV positive and perhaps were not on ART. During the post-evaluation, the HIV prevalence among those tested was over 47%. So this is just a really high prevalence population. Also due to the routine data, so this is, I think, part of what's in the fridge. Viral loads clearly weren't in the fridge at the baseline. But end line, among the 19% who had a viral load done outside of the confines of the study, over 91% were suppressed. And we also did a costing analysis to try to put some of this work into context. And essentially, what you can see here are the unit costs by facility for doing HIV testing in the correctional facility. And they all hover between $54 in Joburg, upwards of $90 in Breed Valley. So these are substantially higher than what you would see in the community. And the reason for that is just because of the additional resources that are required to do testing in a correctional setting. So we need security personnel to be able to escort the inmates to the testing venue. And then the individuals that do the testing, it's not their primary job. Also, the cost for the security accompaniment was also included in this unit cost, and they don't provide direct HIV testing services. But I wanted to spend a little bit more time getting thoughts in the room about adoption, implementation, and maintenance. And so these are two quotes that are pretty illustrative of the issues from the end user patient perspective, as well as the adopters. And so the first one is from a female inmate. And the quote is, "Tremendous changes. It's unbelievable how quickly people are accessing the drugs and how quickly they are attended to." And the second one is from a HIV AIDS coordinator in Johannesburg from the Department of Health. "There was a saying years ago in the prison system that prison has its own time. There's no rush in prison. When the TASK project was introduced here, I think we started benefiting a lot from the extra hands on deck and the fresh thinking of the partners." So these are two quotes that I think reflect some of the barriers and facilitators that we identified through a thematic analysis of our qualitative interviews. And so I wanted to point out that the facilitators and barriers listed at the bottom are not implementation science framework driven. These are early barriers and facilitators, but they were done by a health systems researcher who developed a thematic framework using inductive reasoning and judgments about the relevance, meaning, and implicit connection to answer the question on inmate and system level barriers and facilitators to uptake of the intervention. And so my question is, do those matter? And if not, or can they be better specified by using an implementation science framework retrospectively to better characterize the implementation? So I think there's probably room to use theory and implementation framework to better specify efforts to better specify the barriers and facilitators of our implementation intervention and strategy to try to replicate that intervention and scale it up to other correctional facilities. And so it begs the question, what can we gain that we don't already have from the prior qualitative analysis? So I was just going to make a plug for the CFIR in Paris as a framework that can better explain why and where implementation succeeded and can create opportunities to more precisely specify factors of interest that are influencing test and treat implementation success and failure. So these include things like the object of the implementation, which is the intervention itself, the users and adopters, the end user, the context, and the strategy for delivering the intervention. But admittedly, if we were to do this and apply these frameworks, there's definitely things that we didn't think about in the study design as we developed our in-depth interview tools that we wouldn't be able to evaluate. But the list on the left is the domains from CFR as well as relevant constructs. So you'll see in italics constructs that we just didn't consider because we did this sort of retrospectively. And I won't belabor the point, but for example, with the outer setting, so we talked to correction staff, health workers, policymakers to explore the extent to which they felt patients' general health needs were being addressed, especially around HIV and TB, and how they were prioritized by the various adopters and end users at facility level. However, we didn't consider the influence of cosmopolitanism on, how our intervention would be implemented. So the question I pose is there sort of a standardized or best practice way to apply implementation science determinant frameworks retrospectively to use existing data, both from qualitative interviews and surveys, to better understand the phenomenon of implementation? And how do we go about doing that? Do we recode our interviews? Do we try to map the barriers and facilitators we've already identified onto existing constructs? And then my last question, and relates to the pictures, is more trying to be provocative, and I think questioning the orthodoxy. I'm not sure there's always instances where implementation science frameworks are exhaustive. So the picture of the individual on the top right is Edgar Lungu, who's the president of Zambia and is the lead of the Patriotic Front Party. And on the bottom is the chief opposition leader in Zambia, the head of the UPND, Mr. Hichilema. So the biggest barrier we had in implementation was when the president incarcerated the opponent in our Zambian study site, and essentially all activities stopped because it went from being a civilian correctional facility to a military correctional facility. So movement of inmates was restricted to get testing and ART and to come to clinics. So is there a construct for structural violence? Is there a construct for political prosecution? So these are some of the questions that I raise with you, not to be totally provocative, but to say that there may be some role still for implicit theory complementing explicit implementation science framework theory. So I'd love to hear your thoughts, and that was to Prof. Chasen in the back. And then this is our task study team. Thank you for your attention.
End the talk, begin the discussion.
Thanks for fantastic talks. I look forward to the opportunity to, engage about each of the things that were discussed, perhaps over an alcoholic or non-alcoholic beverage. But to your last point, Mike, I think that was well said. I mean, I think the people who are developing implementation theories sort of see these as works in progress, and therefore, expect there to be refinements sort of going forward into the future. I mean, I think we had a similar experience where we started to, we're doing a systematic review where we want to characterize the implementation interventions, and this big project was just concluded to characterize, ERIC to characterize implementation interventions. I believe there are 73 or 77. Sort of somewhat mutually exclusive categories. And the first study we looked at, we pored over the ERIC framework, and we could not find where it fit in it. And so we decided to sort of not use it. There are other approaches, but all that to say that, I agree that these are things that are works in progress. But I would also, one other comment I have for maybe, Mike, so there, the QI is an interesting field because everybody wants to know if QI works, right? So they're like, okay, we're going to do QI. Does it increase viral load? Does it increase response to strokes? Does it increase response to sort of chest pain in the ER? But really, there's something that has to be done to get facilities to change their organizational behavior to take up QI. And in my mind, that step from that implementation strategy or intervention to the to actually doing QI is a far more interesting question than whether or not QI has an effect on what comes after it. Because QI is almost like a drug to me. If you are actually going to if you ingest the thing, it will have an effect. That's not as true as it is for a drug, but it's close. But the whole field's been focused on, does it quote unquote work? Whereas kind of like, what do you need to do to change the behavior of an organization is a more complicated and probably more interesting and valuable potential question. So just a thought around that.
Yeah, no, I wonder, Elvin, I think my understanding is, at least since 2006, if not earlier, every Ryan White funded clinic had a mandate from HRSA to engage in QI. So you have this landscape where it's part of the fabric of the Ryan White program. So how does that fit into a lens of a scientific portfolio is an important question.
Right. So you as you know, Lisa Hirschhorn and I co-chair that technical working group at HRSA that you're on. But HRSA has this effort right now to evaluate the effect of the CQII intervention using a different diff, right? And so at a meeting in DC like a few months ago, I think what Lisa and I tried to push was just like, let's try to figure out what is actually done as a part of the intervention, document that carefully, and look at implementation outcomes and add that to your thing. Because, I think as the sort of people in this room will feel, like if it works and you don't do those things, you won't know why it worked. If it doesn't work and you don't do those things, you won't know why it didn't work. So at any rate, sorry for taking up so much of my time. Well, I mean, I don't think I don't know enough about HRSA to say like one way or the other. But I think in evaluating there's the CQII sort of work that's being done in HRSA. There's sort of an evaluation process in place, and that focused on like, did it work, right? More so than like what was actually done at the facilities in response to it.
And maybe captured different ways. And again, I think the terminology sometimes becomes confusing, where what someone calls a process measure is part of, implementation science, metrics, fidelity. I mean, some of those things that I think HRSA is measuring, maybe not in the lens of implementation science, in the lens of quality. And this, again, to me, is where I think there's a lot of overlap in these Venn diagrams. And what someone does through patient quality and safety initiative as a hospital administrator might not be done, for IS, but a lot of what they're measuring and how they're doing it applies, as it does for health services outcomes research. So there's this: is it generalizable knowledge, or is it feeding back to the home entity, right? And that's research or not research. But this idea of a learning healthcare, I feel like there's a lot of these things that we kind of put in these silos. And again, maybe it's me oversimplifying it, but in my world, I feel like I walk in all these spaces and I'm doing the same work. And it's just a matter of drawing from these different disciplines. And again, with full respect, there are nuances that do matter and that are different, but there's a lot that's similar. A lot of opportunity for convergence, I think.
I just want to address the last point that you raised, Michael, that about the orthodoxy. And I think this panel really illustrates the breadth and richness of the field and the multiple approaches that can be used. And we live in an age of interdisciplinarity and multidisciplinarity and transdisciplinarity. And so we should use all of the tools available it really begins with, what's your question? And then, how are you going to best answer it? And we shouldn't restrict ourselves to, a short checklist of acceptable methodologies. There are multiple that you all demonstrated really, really nicely. And they're all so different, and they're all addressing implementation and impact. No, there isn't. I hope there isn't something to deal with political prosecutions of opponents. Although, we have Robert Mueller, but we can't send him to Zambia. So you're going to have to invent methods.
Yeah.
If you think about it, because I come out of a background of a lot of TV work, the randomized clinical trial was invented to study streptomycin. it didn't exist. It's not something that was in textbooks going back to 1860. The cluster randomized trial was invented to study isoniazid prophylaxis. That's where it came from. It was invented by George Comstock. It wasn't named to 30 years later, but it was invented to address a problem that needed an answer. So I just think we should embrace diversity of methodology and not be too worried about fitting into boxes. So I think the way you're handling your particular, what's in your refrigerator, to use Elvin's analogy, is based on what's in your refrigerator, and you have to you have to take the best approach. Now, Ingrid, I just wanted to say I was smiling when you presented your first question, because I thought, well, of course you want to say a step wedge cluster randomized trial. Except, Anne and Sylvia and I are survivors of a 27,000 participant, 29 clinic, 11-year step wedge cluster randomized trial. And it's, as Chris said, don't try this at home. But it's a great methodology. You can write a really good methods paper about it. Or a book, yes. Yeah, Larry's got the book if you want, Larry. That's.
Yes, well, I was, just a very hypothetical situation, since by the time, we got involved, the horse was out of the barn, so.
Anyway, so I just thought this panel was great because of the diversity of questions and approaches and types of data. And let's congratulate you all and wish you luck.
Thanks. Great presentations. I like this kind of theme of starting once things had already happened for many of you, because I think that's where a lot is needed. So I'm glad you're pioneering that. Mike, I had a question for you. Did you, and you had a question of what other things could you do, and you might have considered this already, but are you also matching your data to health department data? And I asked just because that might give you a sense of if people drop out or you lose them, is it because they might be going somewhere else outside of the system, or could that just complement and add more data since it's readily available?
Yeah, no, it's a great question. So we do have data to care systems in place where clinics are sending lost to clinic lists to health department matching with surveillance. So we'll have that capacity. One thing that came up over the course of the discussion in thinking about viral suppression, because this is always struggled when you're trying to improve retention and you have clinic-wide 90% suppression, one thing I thought is, could we look at surveillance statewide suppression? So if we have, in these 7 clinics, probably 80% of persons living with HIV receiving this intervention, might the viral suppression metric not be who's measured because they're in clinic, but is it statewide data? So I hadn't thought about that, but another way to kind of tap into other data systems and surveillance, both in terms of tracking participants and our patients and migration, but also could it be a better measure longitudinally of if we're really moving the needle, if we could move statewide viral suppression through surveillance.
So Dennis, really interesting data, right? I know we're back to recording, so we'll talk more in generalities, I guess. So what does that say then? The trend has been basically that Treatall is broadly speaking is working in the sense that it's not had this sort of adverse events to date in terms of crowding out. When we're talking about sort of the value of implementation science, obviously this is an important measure of looking that people are initiating, right, and that to some extent that they're staying retained in care. I'm wondering about where ideas, so you're asking what do you do next? So you listed a sort of a series of demographic type, pediatric, adult, et cetera, based on what idea collects. But I also sort of, thinking back to this framework of where do you really need a Whole Foods in order to sort of answer that next question? Because overall, there's a lot of challenges out there, right? Mortality remains high, viral suppression isn't where we want it in almost any setting where we need it to be. As I think, as Michael's data shows so clearly, in South Africa, you're hard pressed to really find a viral load, even though it's in the guidelines. It's not easy to actually find a state-sponsored viral load that exists within the NHLS system that you can track to an actual human being. And so, I mean, I'd love to understand sort of where IDEA goes in terms of, and leverages implementation research to think about like how you start answering some of the questions of the divide between folks getting on treatment, but like new infections not coming down, I think, at the pace one would have expected, mortality not coming down at the pace that folks would have expected, and so.
Okay, big questions. So I think that IDEA. So what is, I think, notable about some of the work that we do in IDEA is or maybe even from my analysis, is what's missing, right? You didn't see anything really on viral load in sub-Saharan Africa, and while it's being done and while it's part of national guidelines, it's not, I think, being done routinely enough to be able to use it. And same with CD4. Increasingly, we were missing CD4 count at enrollment on, I think, more than 60% of the patients now. It used to be a lot better, but so it does get to like what's in the fridge. And I guess I'm thinking, I mean, you know, and I guess we're moving on to alcohol soon. So I'm thinking about like perfect simple cocktail recipes, for example. Like there are a few really great cocktails that you can make with data like IDEA. It doesn't have, you know, more than 2 or 3 good ingredients, but it can have the impact that you want. And but I think that we can't do some of the things that we'd really like to be able to do. I think it was the reason why I think we're not seeing or we're getting mixed results on what the impact on incidence is. I don't know that we're going to be able to address that with IDEA. I do think it has to do with the fact that the level of immunodeficiency at treatment initiation continues to be, you know, a problem. Like it's in sub-Saharan Africa, the median CD4 count at treatment initiation is still usually below 350, even though we're getting more people on treatment. But I think for us to have that impact on incidence, the way that we saw in some of the trials, like HPTN-052, these were people that were starting treatment with the median CD4 count of 450, something like that. And in the SMART or the Insight START trial, the reduction in mortality that we saw was the median CD4 was like 650 in the treatment arm. So I think that's why we're not seeing the impact on incidence that we would expect. I don't think IDEA can tell you that because we don't have increasingly don't have those ingredients in our fridge, and I don't think anybody does, unfortunately, because of what's going on with the good thing about simplifying the treatment initiation, streamlining it, is that, you know, more people can get on treatment quickly. But from the implementation standpoint and at scale, and from a population health standpoint, it's hard to really know if we're having or close to having the impact that we want to see on mortality and incidence.
And coming to this idea of maintenance, I mean, how do we track maintenance beyond the 4 or 5 year lifespan of a grant? Because I think we're talking about population level impact that, you know, is long lived, and so, I mean, the rapid start programs all look very promising, but we're talking about 12 months of data. I mean, so, you know, what does that mean? And I think you talked some about, you know, the longer term retention and some of those targets and how dynamic this is, even on a short time frame of 1 or 2 years, how dynamic viral suppression can be and sustained suppression in these. So, you know, I don't know how that ties into an IS lens, but it's got to somehow move beyond the framework of the grant into maintenance of, you know, programs longitudinally, to have those mechanisms to assess some of those things that might take many, many years to see the population level impact.
Yeah, and I mean, I think the point I think that I was making, there's a few points, but in my mind, I don't know how much is coming out, but is this that there's a divide, right? That there's a divide between numbers of folks engaging in treatment in IDEA, and you know, we work in a number of the settings where IDEA clinics are in, so we see that when we do actual additional Whole Foods type data collection of just this great divide between the national story around universal test and treat and whatnot, and like the actual like viral load data when available or self-reported outcomes, or, you know, and so I think that it is in that sort of trying to understand again the sort of like the quantitative, like here self-reported treatment and this divide between what we see in terms of mortality, incidence, et cetera, the actual health outcomes. So.
I do think maintenance is a big issue, and maybe CAN does have a lifespan beyond the typical like 5-year RON, but I think, with, just in the small example of the CCMDD program, the South African government, they have a good sense of how many people are enrolled in this program, but not really any sense of how the people are doing on the program. So I do worry about that, just kind of over time and beyond the lifespan of what we're going to be able to measure.
One more question? Or are we ready for one? Looks like there's a question here.
I gave away the mic.
So, not to kick this food thing to death, but there is stuff in the fridge that's pretty old but still edible, and there's for prospective data collection, right? You're never going to get something. Well, actually, there are, but most things are sort of grant limited, right? 4 or 5 years, but in treatment settings in Africa, you have clinic-based databases with 10, 12, 15 years of data now. It has flaws, it has problems, but perhaps those are things that could be managed to some extent. Some of the work we did in Zambia recently, we looked at a 2-year span of follow-up, but included people who had been on treatment for 5, 6, 7, 8, 9, 10 years at that beginning of the 2-year period. So we can't say something about that entire cohort that started with them, because a lot of people are lost and dead and stuff like that. But you can say something about the continued hazard or the continued risk that people face after 2, 3, 4, 5, 6, 7, 8, 9 years on treatment, and they're formidable. We're sort of, it's like 1.5% to 2% mortality a year after 7 years on treatment. So at any rate, just kicking a dead horse here.
And I think we're going to wrap up now, and I'd like to just wrap up going back to a metaphor that Elvin showed us a picture of earlier, which is the kintsugi pottery that is broken. When it's broken, the Japanese art form fills it with gold, and gold is metaphorically related to wisdom. So there's a couple of ways to look at it. One of the ways it's interpreted is that as we age and are more imperfect in our body, we become wiser. But I also think we have a wonderful metaphor for what has happened today and what implementation science is, which is implementation science in many ways is taking what we have traditionally known and used as research and RCTs, et cetera, and very standardized and looked at what we see as broken in that and looking to make that whole and to make that whole with gold. So I want to thank you very much for being here.